let's move on to the next case. And yes, we have case scenario number 3. Let's get to it, please, and thank you.
Okay. The answers are A 59409, 070.1, 077.0, Z37.0, Z38.9. B 59410, 070.1, 077.0, Z37.0, and Z38.39. C 59409, 56810 with a modifier 59, 070.1, 077.0, Z37.0, Z3A.39. D 59400, 070.1, 077.0, Z37.0, Z3A.39. Indications: 31-year-old Gravida 3, para 1 at 39 and 7 weeks admitted in labor. She has been followed in the OB clinic with 12 normal antenatal visits. Stage 1, patient was admitted with a cervical exam of 3/C/-1. She slowly progressed to 5 centimeters dilation. She had SROM at 3:30, which showed light meconium. She continued to labor and reached the end of stage 1 at 10 o'clock, a period of 10 hours. FHT showed some periods of reactivity but responded to stimulation. Stage 2. Duration of stage 2 from pushing to delivery was approximately 3 hours. A pediatric team was present. There was slight meconium staining present at delivery. Presentation was OP with right shoulder, anterior shoulder. There was no nuchal cord. The cord was clamped ×2 and cut, and the baby was handed to the pediatric team. Gender male, weight 3,772 grams, Apgars 8/9. Stage 3, placenta delivered spontaneously with gentle traction and fundal massage and was intact. Vagina and cervix examined for lacerations. Inspection revealed a small second-degree perineal laceration, which was repaired with 3O polysorb in the usual sterile fashion in layers. Another small lateral cutaneous tear was repaired with 3O polysorb and a figure of 8 stitch. Good hemostasis was noted. The patient will return to clinic for follow-up in 6 weeks. You have 2 minutes to solve.
Okay, coders. So have you all placed your answers in? Okay, if not, please give your best answers while we work through the scenario. So we have 31-year-old patient admitted in labor, 12 normal antenatal visit, stage 1 SROM at 3:30. We have responded to the stimulation, and we have stage 2 from pushing to delivery. Baby was handed to the pediatric team, and gender was male, 3,772 gram weight. Stage 3, placenta delivered spontaneously, and second degree perineal laceration was which was repaired with 3.0 polysorb, and patient to return to the clinic in 6 weeks. So the correct answer is going to be option D. And we have in procedure inventory, a vaginal delivery happened, and diagnosis inventory, we have pregnancy, which is complicated by second degree perineum laceration, meconium in amniotic fluid, outcome of delivery, week of gestation as well. So option A, 59409, and option B, 59410 is coding for vaginal delivery only code, as well as vaginal delivery only, including the postpartum care. So my question for you all is, coders, is there a postpartum care given in the scenario? Was there any postpartum care? Let me know in the chat. Okay, I see two response. How about the rest of you? Okay, good, great. Okay, so if you read carefully, you can see that patient was asked to return to the clinic in 6 weeks after the delivery. And also in the beginning of the scenario, it's been mentioned that patient had 12 normal antenatal visit as well, which means we had antenatal visit, vaginal delivery, and postpartum visit included in the scenario, right? Yes, once again, I can see that aha moment coming. Yes, exactly. So we had an antenatal visit, vaginal delivery, and postpartum visit in the scenario, which means option A is incorrect because that's only coding for a vaginal delivery. Option B is also incorrect because it is missing the antenatal visit. And option C, let's review what option C is coding for. It's coding for 4900, which is for a routine obstetric care, including antepartum care, vaginal delivery, and postpartum care. So that's a good code selection. It includes antenatal care and the postpartum care, but still option C is incorrect because it's also coding for 56810. That is for a perineoplastic repair of perineum, non-obstetric, right? So usually the repair after the delivery, which is due to either tear or an episiotomy, that is included in the delivery, and it is not or cannot be built separately by a delivering physician. So perineoplasty, and this one is also coding for a non-obstetric perineoplasty. So definitely option C is incorrect. That leaves us with option D, which is 59400 O 70.1, O 77.0, Z 37.0, Z 38.39, and that's coding for obstetrical care, which include antepartum care, vaginal delivery, and postpartum care as well. How are you feeling, coders, after the last scenario? Good, great. Did the explanation help? Okay, great. Yes, so we reviewed 3 scenarios so far, and They were all emphasizing on how forensic we should be while reading the scenario, right? Okay, great. So with that, we are saying a goodbye to female reproductive or genital urinary system, and now we are moving on to the next chapter that would be nervous system, right? Okay, so we have case scenario number 4 for nervous system. Skataya, please and thank you.
Okay. What are the CPT and ICD-10 CM codes reported? A 61322, I60.11, B 61312, I60.11, C 61154, I60.11, D 61323, I60.11. Operation performed: right-sided decompressive hemicraniectomy with duroplasty. Complications: none. Anesthesia, general endotracheal. Estimated blood loss approximately 400 milliliters. Indication: the patient is a 56-year-old male with significant past medical history who came in this evening with an ischemic infarct to his right middle cerebral artery territory, which converted to a subarachnoid hemorrhagic transformation. The significant shift was following commands on the right side of hemiplasia on the left side. After a thorough discussion with the family, we explained to them that this would be a life-saving procedure and we could not ensure that there would be any further neurological improvement from the state that he was in. They understood these risks and wanted to proceed ahead. Operation performed. After informed consent was obtained, the patient was taken to the operating room and induced under general endotracheal anesthesia without incident. TEE monitor was placed due to the patient's significant cardiac history. At this point, a roll was placed underneath the right shoulder and the head was placed in a horseshoe reverse question mark. This area was thoroughly prepped, draped in usual fashion. A 10 blade was used to make an incision sharply. Rainy clips were applied to the skin edges. The temporalis fascia and muscle were then resected with the cutaneous flap anteriorly. This was done until the keyhole could be identified. The muscular cutaneous flap was then retracted with towel hooks, rubber bands, and Alice clamps. The perforator was then used to make several burr holes, approximately 6 and a foot plate was then applied to perform the hemicraniotomy. We assured that we were off midline to make certain that we did not get into the sagittal sinus of any draining veins associated with this. Once the bone was removed, hemostasis was obtained. The dura was opened in the C-shaped fashion and a large piece of durapair was placed underneath this. There was a small subdural clot, which was also evacuated, and the large piece of durapair was then used to create a duroplasty. This was stitched in several points with 4O nylon. Hemovac was then tunneled through as well. At this point, the gallia and the temporalis fascia were then reapproximated with ovicral in interrupted fashion, and the overlaying gallia was reapproximated with ovicral in interrupted fashion. The overlaying skin was closed with staples, and the hemovac drain was secured with 2O nylon. At the end of the case, all counts of the needles and sponges were correct. Coders, you have 2 minutes to solve.
Okay, Chorus. I think I gave you all some extra time on the scenario. So thank you, Miss Katoya, once again. This was also a big scenario, long scenario, but you all did a good job. So let me highlight the keywords here. We have right-sided decompressive hemicraniectomy with duroplasty, ischemic infarct to his right middle cerebral artery, subarachnoid hemorrhage, general endotracheal anesthesia. A number 10 blade was used, incision was made, and several burr holes were also created. Hemicraniectomy was performed. Dura was opened in C-shaped manner. Large dura pair was placed underneath. Duroplasty was performed as well. So that's all we have. In procedure inventory, we have a right-sided hemicraniectomy, decompressive hemicraniectomy procedure performed, and duroplasty as well. Diagnosis inventory, subarachnoid hemorrhage in the right cerebral artery. So in this scenario, we do have a 57-year-old patient who came with ischemic infarct to his right middle cerebral artery, which was later converted into a subarachnoid hemorrhage. So a subarachnoid hemorrhage that will lead to an increased intracranial pressure. So golden standard, or first thing, or the main thing which a surgeon will perform is to undergo the patient with a decompressive hemicraniectomy procedure. So what happens during this decompressive hemicraniectomy procedure is that the surgeon will be opening the skull, and a dural area surgeon will open up the skull, and the dural area will be allowed to swell. That will helps, or that will prevent the from further the brain further getting compressed, or which will prevent further damage to the brain. And this opening of the skull will lead to reduced pressure, or reduced intracranial pressure, and then protects the brain as well. So that's a decompressive hemicraniectomy procedure. So with the image also, you can see how it is performed. There will be separate burr holes created, and the skull, the one on the upper portion of the skull, will be opened, and the dura area is also removed. So the brain will swell and pressure will be decreased, after which a dura material, which is known as a dura pair, which is a non-synthetic dura substitute for repair of dura matter, which is commonly used for the neurosurgical procedures. You can see the image of dura pair as well. And once the brain pressure in the brain is reduced, the dura pair is placed, and duroplasty is also performed. Okay, so that's all about the procedure. Now let's come back to the coding portion. So we have option B, 61312, which is coding for a craniectomy or craniotomy for evacuation of hematoma, supratentorial, extradural, subdural. So cross-checking with the procedure inventory, we had a right-sided decompressive hemicraniectomy and not a craniectomy for evacuation of the hematoma. So both are different procedure. We had a much broader procedure performed in this scenario. So option B is incorrect. Option C is again coding for 61154. That is for burr hole with evacuation and drainage of the hematoma, subdural or extradural. Once again, it's not the same procedure. We had decompressive hemicraniectomy, and option C is just coding for a burr hole creation with evacuation of the hematoma. So option C is also incorrect. Now between option A and option D, option A is coding for 6361322, which is for craniectomy or craniotomy, decompressive with or without duroplasty for the treatment of intracranial hypertension with evacuation associated parenchymal hematoma without lobectomy. And 61323 is coding for a craniotomy or craniectomy, decompressive with or without uroplasty for the treatment of intracranial hypertension with evacuation of associated intraparenchymal hematoma with lobectomy. So only difference is that 61322 is coding for without lobectomy, 61323 is coding for with lobectomy. So lobectomy was whether the lobotomy was performed in our scenario. Let's cross-check with the procedure inventory, and I can't see any lobectomy procedure performed here. Lobectomy will be the surgical removal of a portion of or a portion of the lobe of the brain, which was not performed here. There was no lobectomy performed. It was just a decompressive hemicraniectomy along with uroplasty. So I would say no lobectomy was performed, which would eliminate option D. And the correct answer, as most of you have said, yes, most of you have said the correct answer. It's going to be option A, 61322. Okay. So how are you doing, coders?
Thanks for tuning in, and until next time, happy coding!